Sorry. Okay, everybody, good morning. Staff meeting Tuesday, October 7th. Got a few things we're going to be talking about. Tom, take it away.
We do. We have multiple things to talk about today, but we'll want to talk about WIC before we leave today, but want to give Lindsay a chance to get settled, and I want to make sure Adrian Byrne is on Zoom, so we'll skip that for now. I want to talk a little bit today with the commission about certified community behavioral health centers, the CCBHC model, and Michelle Calvert is here to kind of just give the commission an update on that migration that we went through back in 2022 to get commission up to speed on that model. Jennifer Wilson's going to be right behind her to give the commission an update on the crisis center, the new build, and Andrew Diltz will be here to support her on that. And then Tanya has a couple of items: on-call realtor, which we're waiting to put back on to a commission agenda. We want to talk about that in staff, and then legislative platform. And then we'll probably swing somewhere in there. We'll come and talk about WIC too. So those are all the topics for today. So Michelle, I'll let you jump in first here. Go from there.
Hey, good morning, Michelle. Welcome.
My hope is to give you guys enough information to understand CCBHC a little bit, but not too much. So where does CCBHC come from? What's the start of it? So if you think back to the 1800s, where people were institutionalized a lot for mental health problems, the government was realizing throughout time that this wasn't very effective. So in the 1900s, we moved towards a community-based model of care. So it was costing a lot of money previously. We wanted to adjust, bring people into the community, make them productive members of society, right? So we moved towards community mental health centers. And it wasn't actually until around 1970 that counties were allowed to use mill levy funds to actually help fund some mental health care. So 1970s was when that was brought forward. And then CCBHCs were brought into play around 2015. So if you look at mental health care over time, there have been a few phases of mental health reform. CCBHCs are seen as mental health reform kind of 2.0. So 2015, the federal legislation was passed for the Excellence Act in mental health care. At that time, there were 8 states that were becoming demonstration states. They were moving towards a CCBHC model of care. Federal government put some money into it a little bit further. In 2020, we actually applied to become a CCBHC. We were not granted that grant, unfortunately. However, we all know what happened around that time. The COVID pandemic really took a hit for the mental health care of our country. Federal government came back and said, hey, you said you could become a CCBHC. Can you still do that? Yes, absolutely. So in 2021, which was the last time I was up here talking to you guys about CCBHC, we did receive that grant. So we took a couple years to work towards becoming a CCBHC. And in 2022, we received certification as a CCBHC. So this focus today is really talking about what that means to you guys. So next slide, please. Can I move the slides? I can. Never mind. I got it. Sorry. Thank you. So what does it mean to be a CCBHC? So we have to have 6 core areas. We have to have a level of staffing that allows for us to provide services to the community based on a community needs assessment. So we want to get an idea of what the mental health care is in our community. CCBHC's huge focus is on accessibility of care. So we want to be able to get people into care quickly and help them move along through care. Care coordination is the golden thread of a CCBHC, and I'll explain that a little bit more as we're going. There's a broad range of services that must be provided as a CCBHC. You'll see that here momentarily. There's a lot of quality measures and reporting that goes into this. And then we have to have governance. And as a CCBHC, that governance has to include individuals who have lived or shared experience in mental health. So we want our care to be guided by individuals who've lived the life and walked the walk. So that's where that has come from. So the core services here, there's a broad range of services. If you look up here, for those of you who have been familiar with ComCare for a while, you can see that a lot of these services we've been providing for many, many years. ComCare is the largest community mental health center in the state. And I like to tout that we are well respected and other centers come to us because of how well we do the services. A lot of these services we were providing before becoming a CCBHC. So as we became a CCBHC, we just improved those services. We expanded the services. So we were able to provide more evidence-based practice. We expanded, expanded our mobile crisis services. We expanded care to veterans. So these highlighted areas are ones that we did put a little bit more effort and energy into because we were already doing the other ones quite well. A huge component of CCBHC is looking at mental health and physical health, how they're tied together. If you look at all individuals who receive Medicaid funding, 20% of those individuals have a behavioral health condition. However, that 20% makes up for 50% of Medicaid spending. So what that's saying is individuals with behavioral health conditions are making up a lot of the spending for Medicaid. CCBHC is focused on Medicaid patients. So the focus is trying to get those patients into care within the community in a way that is less expensive overall. So it's reducing the amount of times they're going to the ER. It's the reducing the amount of time they're spent in the hospital. Does that make sense when you think about the financial aspect of it?
Yeah, you might clarify. I know it's focused on Medicaid, but CCBHCs are obliged to take all individuals, whether they have the ability to pay or not.
Yes, we must take all individuals. So I'm going to talk a little bit about the funding piece of that and where that question might come into play.
Okay, good.
So
Thank you.
hang with me there. So looking, those highlighted areas are areas that we really boosted. We also boosted one of our specific teams that is called an assertive community treatment team. And that team is focused on treating individuals who are really hard to get into care. So that's a team approach to our high utilizer patients. And we've seen some really good success with that. So, and talking about that physical health component, I want to point out to you guys, this is more of just a DIY so that you have some good information. This bottom part here, 20% of our health and wellness is made up of what happens when we are in the doctor's office. So think of doctor's office, mental health clinic, 20% of your health is made up based on that appointment. The rest of your health is determined by socioeconomic factors. So your education, job status, where you live, the support you have, your physical environment. So 50% of our wellness is based up on those socioeconomic factors in our physical environment. Then 30% is made up of tobacco use, diet, exercise, alcohol use, and then the way we communicate with others overall. So when we look at our patients, social determinants of health is what you're looking at here. We assess every patient for social determinants, and this is kind of a buzzword in the mental health field, so you might want to have that on your radar. But what we're trying to do is we're trying to impact more than just their emotional health. We're trying to get a feel for what's their job status, what's their housing status. If those things, along with their physical health, are boosted, their mental health is going to get better as well. So talking about CommCare revenue funds, I think you guys have seen this a lot, especially with the budget season having been recently. 65% of our funds are based on encounters. So that's us working with patients overall. And when you look at that, about 85% of our patients are being paid for through Medicaid spending. So I want you to get an idea of where our funding is coming from and then how patients are paying for care. Most of it is Medicaid. There's a small portion that's self-pay, commercial insurance, state-funded Medicare and contractual. Those are all related to other things like gambling addiction treatment or addiction treatment overall, the way those are paid for. Any questions with any of that? Okay. So CCBHC, one of the huge impactful pieces is that we have this PPS rate, the prospective payment system. So prior to being a CCBHC, if I provided an hour of therapy to somebody, we got paid as a fee for service. We got paid for that hour of therapy. Moving towards the PPS rate as a CCBHC, we look at all of the services we provide. So prior to CCBHC, we were providing millions of dollars of free services. We could not turn away a patient. As a community mental health center, we cannot turn away a patient. We are the safety net for this community. As a CCBHC, we are still the safety net. But what the CCBHC does is it takes into account the cost of providing care to the community. So we look at all of the services we provide, do a little math, it's a lot of math, and figure out what that cost is per day. So we get paid as a daily rate as opposed to fee for service. So this is where it takes into account all of the care that we provide that we may not have been reimbursed for previously. So when we moved towards that CCBHC model of care, we were really able to impact not only our patient care, but also our staffing. So our staff, we were able to increase salaries to what really was needed. And we've been able to maintain our staffing quite a bit more over time. So this has been life-changing for not only our community members, but also our staff.
So a question on this real quick. I'm sorry to interrupt, but I think it's important for us to understand the context of how this PPS rate compares. So obviously, part of this rate structure is care for those that are uninsured,
Correct.
is the community safety net. How does our reimbursement rate compare to other organizations in the community that are not CCBHCs?
Well, other organizations have a much higher percentage of patients that they serve that are private pay patients, and they don't have to take all patients. So it's kind of comparing apples to oranges.
Sure.
They don't have a prospective payment system in place. So their rate is very different. They're still on a fee for service rate.
And a fee for service rate is typically what compared to what we receive on a reimbursement? Do you have any context at all?
That's hard to say because
I guess the
every
question I'm
service
asking,
is different.
how much more are we getting than the average organization out here because of the community safety net model of being a CCBHC? Is it?
I wouldn't say
considerable?
that we're coming out way on top because of the amount of services we have to provide to those who are uninsured.
Agreed. Okay.
So I don't know that I could give you a good example of a payment difference, because an hour of therapy for us, if we were on a fee for service, would be the same as the hour of therapy for them.
I'll let the cat out of the bag where I'm heading with this train of thought is that we're receiving a higher reimbursement rate, and these dollars are intended to get invested back into the community to provide services for the community, not to
Yes, I hear what you're
pay
saying.
interest in an account. Yeah.
However, let me tell you this though, if you call maybe not every, if you call many therapy offices in Sedgwick County and you're calling them after hours, the message you are going to get on their phone is, if you are in emergency, call crisis. While we're not supposed to be the backup for the community, we are the backup for the
Sure.
community, and that takes into account some of
Agreed.
that as well.
Okay, that's helpful.
That makes
Thanks.
sense. Yeah, for sure. All right. So here's our prospective payment system. If you have a question about that, any others? No. Okay. So let's talk a little bit about what CCBHC has meant to our community and the impact that it has made here. The access to care has been substantial. So we kind of look at this in a few different categories. We look at serving children, serving adults, and then also looking at our addiction treatment services. So you can see that in 2022, we served 861 youth. And then in 2024, we increased that to 1,700. The really cool thing about this, though, is that we served that many more children sooner. So in 2022, it was taking us on average about 14 days to get a youth into services. We can get them in today. The average right now is less than 2 days, but we can get them in today if needed. For adults, the number increased as well, but now we can get people in less than half a day. Our addiction treatment services, here's one that's really impressive. 372 served in 2022, 509 in 2024. That average wait time was 36 days, and now it's less than an hour. So that's just looking at getting somebody into treatment. When we look at crisis care, I'm sure Jen will talk more about crisis, but I'm going to share as well. One of the requirements of a CCBHC is that if somebody calls in and they need a mobile team, we have to serve them within an hour. On average, we're getting them to them in about 33 minutes. So we're able to meet and exceed those requirements. Part of that's because of staffing, but we've had some strong efforts to really get people in quickly and serve them as quick as we can. So looking at community partnerships, this is another big focus of CCBHC. This is not an exhaustive list of partnerships. However, we can see that prior to CCBHC, we had around 99 partnerships. It's more than 114 now, if you see on the bottom. We've expanded partnerships quite a bit. There's been big focus of partnerships with FQHCs as well, school systems, and then other providers around the community. So when we look at that physical health care component and mental health care component, we want to make sure that our patients are getting into a primary care provider. So we've been able to communicate with FQHCs to try to help out in that process as well, because an FQHC is the safety net of the medical world, or we're the safety net of the mental health world here. And then the top number there is looking at care coordination. So like I said before, care coordination is the golden thread. So if you think of a patient who may be coming to us and receiving care, if they're receiving medication with us, therapy with us, they have a primary care provider who may be prescribing medication for blood pressure. If we're not communicating, we don't know if those medications are working for or against each other, right? So this is just an example of where care coordination is important. We want to make sure that we have all heads in the game, and that's going to help patients move towards success faster, and then they can move along through care. We have a couple different contract providers. So we're the Community Mental Health Center and CCBHC of the county. We have Mental Health America, who provides contractual services through our license. So they serve about 20% when you look at the number of encounters we provide to the community. These numbers are looked at from January through August. So that's the number of services we've provided overall in that period of time, if you didn't know. So MHA has provided about 18,000, 19,000. Pyxis is a provider that contracts through us. We're the primary providers, and they're providing some ancillary services. And then you can see the amount of work that we're doing with patients as well. Questions about this? MHA provides case management services similar to what we do. They just do it under us.
I would just want to publicly thank ComCare leadership for really digging in the last year on some of these partner relationships. I know we talked about the reimbursement rates and the contracts and all of these things. I just want to publicly thank for the investment. You spent a lot of time on this.
Yes.
And you heard from the will of the commission that we wanted to expand these partnerships and protect these. So just want to publicly thank you guys. That was a lot of work.
Yep, it was. And it's really important that we have providers around the community who can also do some of this work alongside us, recognizing that you see what it takes to be a CCBHC, and it's extensive. It behooves our community to work with us to be providers in that, as opposed to having multiple CCBHCs, because then there would be more duplication of care. All right, what's the future look like for us with the CCBHC? We approved within the previous budget, we're going to be expanding our care coordination efforts. And a lot of this is focused on partnerships. So we're going to have 2 of our care coordinators based in Second Light. We already have 1 in there part of the time. And then once we can hire that up in January, we'll be able to be there more full-time. We've had some great success there already. It's been pretty exciting. We're going to have a care coordinator focused on mobile care. So our mobile teams will have some care coordination that can be associated with them. 988 follow-up. Jen's going to talk about 988 and what that looks like, but we're really expanding our chat and text and our 988 calls that are coming in. Some of those need some follow-up. So we want to be able to provide that as needed. For individuals who go to the ER or are hospitalized, we want to be following up with them so that they can get into care more quickly so that they don't get hospitalized again. At drug court, we'll have some care coordination, and then we'll also have some care coordination associated with housing as well. Any questions for me?
Thanks, Michelle. I think we were going to talk. This was a really good presentation, and yeah, a good 15, 20 minutes. Some of the data in here, I think you've covered some of it before, but updating this is incredibly valuable. I think you're being invited to present to our advisory board. So I think now that I've seen this, that they're going to really love this, which means also I think this news needs to get out in the public better. Maybe it is, and I just don't pay attention, but this is really, these numbers are very positive. This is a very positive statement that we're involved. And I really like that we have 2 people at Second Light. I think I'm scared about everything going on at Second Light and hoping that it's going to be a success. And I know we're at baby steps, but if ComCare and if we're doing our share to support that Second Light through ComCare with 2 agents, I think that's very valuable.
I think it will be. I think it will be a success. And we've recently put together several different bits of information that are beautiful data points similar to what I shared. And I think those are some things that we could help push out into the community to help folks see and understand.
Thank you for that.
Thank you, Michelle. Whenever we discussed the PPS rate, did you show us a rate or any trend data as to what that's doing or do you?
I did not show you a rate or the trend data related to that. That's different across the state. So it's every center has a different PPS rate based on their allowable costs and the services that they provide. And that rate changes. It's not something that stays static. We look at it, so far we've looked at it 2 or 3 times, and then we will be able to look at it and reevaluate it every 3 years. So the rate will change.
Okay, what kind of, I mean, can you tell us what the trend has been and how we've exercised that data?
It's hard to say. Our rate has gone up, but our staffing has also gone up as well. So when we look at the allowable costs, that has driven some of the rate to go up. We want to get the rate close enough to where it's showing we anticipate providing this amount of services in a year. There's a window there. We need to get close enough to keep our rate, but we don't want to get so far above or below that we end up having to pay any money back.
Forecasting tool.
Kind of, essentially, yeah.
I think the important part to remember about the rate is now it's a cost-based rate. And so we're able to identify all the costs associated with the services that we provide. And that's how the rate is set. So we submit data and it calculates that rate. And then that's what the state agrees to in the old days. And if you go to your physician, there's a rate that's set by the payer. So whoever your insurance carrier is, United says, I'm going to pay $125 for a 15-minute visit with the physician, and it's dictated by the payer. In this instance, now we're able to say, here's how much it costs to deliver that service, and we get reimbursed for the cost. And so it's a completely different way of understanding how the rates are set.
Other questions, Commissioner Hill?
Thank you, Mr. Chairman. Just a couple of quick questions. On page 3, my number this is talks about the housing grants is 1%. Is this specific to CCBHC, or is this how the county doesn't have a lot of housing grants? I'm just trying to figure out what is it referring to when it says 1%.
I think is part of CCBHC requirements is to have housing and
There
might be
is a
getting at the-
requirement to
yeah.
do care coordination for housing. So we don't have to provide housing. What we need to do is help patients get connected to housing, if that makes sense. So it's not a requirement that we be a housing provider, but we need to help connect our patients who are struggling with housing.
And I'm just wondering, with the shortage of housing, it seems like it might be a problem for us to understand more deeply. I just wanted to.
Yeah,
Is that
so
what-
one of the things I will mention is that we are being very active within those efforts in our community. We're trying to be at the table to help provide mental health care wherever housing is being focused. So when you look at One Rise or Second Light, we're at those tables trying to make sure that we can support as much as we can.
Thank you for that. I'm just also curious about the next page. You talked about the average number of days from call to initial evaluation on addiction treatment services down from 36.5 down to less than 1 hour.
Yeah.
That means to me, that means there is no waiting line any longer.
There is not.
There's not.
Mhm.
And when you talk about services, treatment services, what type of services are we talking about specifically?
For this slide in particular. So what this looks at is a patient walking in the door or calling to get an intake. So they get an intake for services, so an assessment. And at that assessment, we're looking at what diagnosis is there, what impact is it having on their life, their family, their social supports, and then what are our recommendations to them to help progress them in care. So this is looking at getting them into an intake for care and then following those recommendations.
If they need some type of medical detox, is that available?
So we don't have, SAC has a detox unit, and Jen can probably talk a little bit more about that, a social detox. There's no medical detox. That's one of the gaps in our community.
And I think the opioid settlement funds, in my opinion, should be provided for that. That's one of the things I'm advocating for. So again, so what this is talking about is really just the intake, and the evaluation is less than 1 hour, but whatever services might be needed after that intake
Right.
is really not solved. There is a waiting line for that.
dependent on what they're looking for. Yeah, if they're needing medical detox, that's not through us, but we would definitely want to help move them towards where they need to be. But yeah, like we said, there's a gap in the community for medical detox.
Okay, and then on the next page, they talk about 7 added positions. Some of this is already done.
Mhm.
It says future focus, there's 7 added positions. How much of that you need to plan for in our budget out of this 7?
They're in the budget for 2026, sir.
That's all my questions for. Thank you so much.
Thank you.
Just a quick one to follow up on that. The second light, the two, yeah, can you answer? Do they have built you an office, and do we have,
So we know
I
that
know
we'll
the
have
country
space within Second Light.
you do?
And we're still, so they will have some provider space in Second Light. And then we're looking at having places for them to be able to provide some care and treatment as well. So we're looking at having the option of telehealth care. Crisis is going to be very present around the area for Second Light. But there will be spaces for our people to be based and also spaces for them to be able to provide care within the building.
Thank you.
Okay, Michelle, thank you very much.
Thank you.
Who's next, Jen? On cue. Good morning.
Good morning. Jennifer Wilson, Director of Crisis Services, and I'm here to talk to you about the Community Crisis Center. This is really the future in our work towards expansion. I'm not going to talk in detail regarding the services specifically, but if you have any questions as I'm working through this about the services we provide in the details, I can answer any questions. So currently we're operating crisis services out of 2 separate buildings. We're at 635 North Main and 1720 East Morris. At the 635 North Main, we're primarily providing the acute crisis services. So walk-in screening and assessments, mobile crisis care that's offered 24/7, crisis observation unit, which is stabilization for up to 23 hours. That includes crisis services and case management and observation. And then 988 and the local crisis hotline, which is also telephone call and chat and text we've started implementing for 988. So we're providing those services out of the Main Street location. And then we partner with the Substance Abuse Center of Kansas and offer that social detox piece that Michelle referenced to, and some of the sobering and detox services, I should say. Our work is to combine both centers because at 1720, we're providing that longer term stabilization. So if people aren't able to achieve stabilization within that 23-hour period at our Main Street location, we'll refer them over to ongoing stabilization at the 1720 East Morris. And then we have some offender assessment program services also provided out of that location, which includes the mental health court, some of that auxiliary case management services for the specialized populations, and then our liaison work that includes hospital liaison and correctional facility liaisons. They're all officed out of that 1720. So we're wanting to centralize all of those services into one location, which you'll see on your right, the layout for the new building, which is over on Topeka.
Real quick, is 1720 owned or leased by the county?
It's leased.
It's a lease building. Okay.
So our crisis expansion goals will allow for better coordination between providers and ease access of care for patients. We're really wanting to develop an environment that's welcoming and therapeutic for patients requiring that crisis stabilization. And we're wanting to work on becoming and operating as a crisis intervention center. It's an entire new model of care. It's recognized statewide and nationally as the way to provide crisis stabilization to those in acute psychiatric crisis. It will enhance the interventions that we're providing to patients, and it will work on providing stabilization services to those with more serious mental health needs. We've been making do with our limited space now. As I told you, we are in 2 buildings. We've expanded 988 and mobile crisis care considerably over the last couple of years. So our 988 services are provided in 2 different spaces. Our stabilization unit and our observation unit are in 2 different buildings. It makes that collaboration, referral, and providing that stabilization care difficult when we're split up. So the idea is to have everyone close together, be able to make that referral piece seamless and provide quality care quickly. So with the move and centralizing services, we plan to also enhance and expand the services that we're providing. So moving crisis observation beds from 6 beds that we currently have, recliners actually is what they are, to 8. Stabilization beds from 6 stabilization beds to 13. And then sobering beds from 8 to 10. And then those detox beds that we were talking about earlier from 15 to 24. It's not only increasing the stabilization beds by 7, but like I had mentioned before, and we'll talk a little bit about Crisis Intervention Center in a minute. We're really changing the way that we're providing crisis stabilization care. Right now, over at Morris Street, we're licensed as a residential care facility. It's like 2 pages of state regulations that we have to follow, and we're moving towards a crisis intervention center, which is 70 pages of regulations and 47 individual policies. So it's a complete enhancement of how we're providing care, hopefully providing relief to the community in other areas.
Jen, can I interrupt? So that previous slide. So under the current, so are you maxed out with those numbers? Or
Are you talking about
how'd you get the estimates from 6 to 8? How'd you get from?
Are we currently utilizing 100% of the beds all the time? We are, since COVID, we've come to pre-COVID numbers. So we are enhancing or utilizing those services much more frequently than we were, because there were some limitations with some of the distancing requirements and stuff with COVID. So stabilization was tough on a community basis, but we have been utilizing it higher. And we are utilizing our psychiatric inpatient space fully. So we were boarding patients for days in the emergency departments, and expanding to 13 stabilization beds as a CIC will help provide relief in that aspect as well. So hopefully people can not require that higher level of care and get stabilized at our center.
I was just getting ready to ask, can you really help us understand the difference between a crisis center versus a crisis intervention center? And then I looked at the next slide. So
we're going to get into the details of the crisis intervention center because it is a completely different.
It is, and that's what, so I'll just wait patiently.
And then, yeah, because the next several slides are about the staffing and the services that we provide.
Okay.
All right. So again, we'll be licensed as a crisis intervention center by KDADS. The care right now we're providing is for voluntary only patients. In a crisis intervention center, it allows us to provide patients voluntary and involuntary care. So right now, we'll refer all voluntary care either to our stabilization center or an acute psychiatric hospital. If they require involuntary care, we're referring to, we have a few beds that are state hospital alternatives at Via Christi, but all the other beds are either in Olathe or Osawatomie. So we are having to get them patients to those facilities to receive that level of care. We'll have 24/7 access to medical providers. So right now we have a psychiatric APRN available just during business hours, 8 to 5, that provides medication management services to those in our stabilization units. In this model, we're going to have RNs, APRNs, and a physician on call available around the clock. Referrals can come from multiple community partners, including the sheriff department, police department, jails, hospitals, or other community resources that might be serving the population. And really the focus is it's going to provide quick access to care. Right now, when a person is deemed inpatient is deemed necessary to provide that treatment and stabilization, a patient can wait hours to days to get that referral to that bed, where when we determine the need, we can start that service right away at our center. So there's no delay.
Can you help expand on the involuntary commitment piece of this? I think that's something that I want the community to understand. If they're in need, if they're in danger to themselves or others, determined by a medical doctor.
Licensed qualified mental health practitioner.
And right now, the only places in our community that take involuntary commitments, is it for 72 hours? Is that what we're looking at traditionally?
So there's a 72-hour observation period in which you have to get them petitioned by. And so our screener at the crisis center provides that assessment, determines what the medical necessity is for stabilization services. And we always try to make voluntary treatment the first option. So we want to get connected, build that rapport, get the patient agreeable to an admission if that's what's necessary. But then if they don't have capacity to make informed treatment decisions or aren't willing to safety plan in order to sustain safety to themselves and others, we would petition the care and treatment courts for inpatient hospitalization. And then they would order the inpatient treatment order. They would make that order, and then we would transfer and make the referral to the state hospital
To the state hospital. Got it.
or the SIA, the state hospital alternative.
And right now, the alternative is what, St. Joe?
We have St. Joe and Cottonwood. Cottonwood's in
Right.
Olathe.
Now, this is a change. This is different.
They keep changing.
Yeah.
And I think that the other important piece, because that doesn't make this, because I know that you all are probably thinking you have a state hospital that we're building. We need those beds. Well, those beds are still needed. But what we want to do is not have patients who could stabilize in a lesser restrictive setting take up those beds. We want to make sure that people are in the right bed at the right time for dependent on what the need is. So this will allow for us to serve those who can be stabilized in a less restrictive setting and then reserve those beds for those that are needing that more intensive level of care. These are some of the benefits of crisis intervention center services. Again, 24/7 stabilization provides immediate support to individuals who are in behavioral health related crises. It's an alternative to hospitalization in jail. So instead of people not having their mental health symptoms treated and getting arrested for those nuisance types crimes, we can get them connected to stabilization care. Again, serving voluntary and involuntary admissions, that's a huge change. It's an incredible lift as well. We're assessing and triaging immediately and making those referrals so people can receive those services quickly. Short-term stabilization stays. We're looking at up to 72 hours and longer-term stays if needed. There are some patients that require more than 72 hours for stabilization. So if it's clinically necessary for them to stay longer, we can reassess need and have them stay as long as that's medically necessary. And then providing that medication management piece. We provide that now, but again, the provider's only available 8 to 5. So we're trying to get that service offered 24/7. And so they can receive medication immediately upon admission when that's needed, obviously. The therapeutic interventions include case management, crisis de-escalation, some of the support to stabilize and improve the person's functioning. Like Michelle talked about, whole health care is really important when it comes to behavioral health. So medical providers are on board. They screen for medical issues and make referrals when necessary in order to support that stabilization. Case management and care coordination are very important. So if they're connected, say, to our adult services program and then admitted to the unit for stabilization, we can have care coordination, reach out to the case manager and say, hey, we've got Joe over at the stabilization center. You want to reach out, get them connected, make some referrals to help support their stabilization once they discharge. So we're discharge planning from the time of admission, getting them connected to that ongoing care. And then, of course, keeping them local where they're at, helping ensure that their family and loved ones are engaged in the treatment options. That's really hard to do when someone's receiving services out of town. So providing them locally and local services in order to help encourage engagement with families and support systems. The Crisis Intervention Center is expected to have substantial community impact. Again, really want to emphasize the importance of access to care. People are waiting hours to receive care, sometimes days. So they are receiving it immediately at the time of need. It will allow patients to seek care in the community where they reside. I talked a little bit about the demand on state hospitals. It will help relieve some of those demands in the emergency departments. And then the public safety system. Right now, if someone has to be taken, say, to the hospital by a law enforcement officer, they have to take them, get them through triage and stay with them until they're in a secure spot. That could take hours. So it takes a law enforcement officer off the streets for that time. If somebody requires transportation from our center to a more secure setting, like the hospital, we call and ask for law enforcement transport to get them securely transported to a hospital setting. So the idea is to provide treatment at the time of need, lessening the demand on the public safety system. In order to prepare for becoming a CIC, we put together a crisis intervention center quality improvement charter. We recognize that it's a heavy lift. As I said, we're going from 2 pages of regulations we have to follow to 70. That's quite the change. And it's requiring a lot of intentional planning in order to get there. So we're really getting everyone together within ComCare and the community in order to really take a deep dive into those regulations and policies and then plan accordingly. The team, which on the next slide, I'll explain who's members of the charter, but then we're also trying to engage. There's ad hoc members that will engage as we need it. So for example, KDAD's joined a call in order to review our floor plan to make sure that it meets all of the elements that are required for a crisis intervention center. When it comes to educating the community about our program, we would engage communications on how we can make that push and outreach efforts for other community partners in order to help them become aware of the services that were offered. Safety and security will involve police department in order to make sure that public safety is considered and the safety of our staff and our environment within the crisis intervention center are considered. So we're trying to engage as many people as possible in order to plan right. And then we're reviewing the positions that are required. So within all the regulations, it outlines all of the required positions in order to run the crisis intervention center. So taking a deep dive and gain understanding of what that's going to look like, which we again will go through in the following slides. Just a list. This includes the leadership within our crisis department, our quality assurance team. Joan Abby's our nursing manager director. So she's really understands the medical piece and the components outlined and the responsibilities and limitations that certain licensures might have. So really focusing on what will be added to from our current practice to the future would be medical and psychiatric care. APRN positions would act as the clinical director and review and approve admissions. So they have to screen everyone referred to a crisis intervention center to make sure that they don't have communicable diseases, they don't have medical issues that would impact their stabilization, or if they do have chronic conditions, they're receiving care necessary when they are admitted. So that would take an APRN to make that referral and approve that admission. An APRN would ensure that we're operating to standard and meeting all of the contractual obligations, which include some of the laboratory services, the pharmacy services that are required. The persons with lived experience, so we have peer support specialists. It's very important to involve people with lived experience in the treatment process. Having someone understand what individuals are going through and be able to provide some support is paramount. And then also clinicians. Therapists are the ones that do this screening and care and treatment petitioning. And the same person who makes the referral cannot do the reevaluation. So it's going to take a few other positions in order to be able to manage those demands. So Abby looked at our current staffing requirements and the regulations, and we're toying around with some ideas on regarding how we currently practice nursing and how we might need to change in order to meet the demand. So right now, RNs are currently exempt, and we're exploring changing them to non-exempt because sometimes staffing challenges could impact our ability to staff. So if there's weekends, hard to fill positions or such, and we would want to make sure that nursing is compensated for that. Benefited part-time RN positions are another possibility, which would allow for those gaps that full-time positions can't fill. It would allow an opportunity for that, but not necessarily take another full-time position. And then right now we have some bonus pay clinician positions, which help fill those really hard to fill shifts. We're looking at nursing as possibly having that as well. And then the APRN, right now, the APRN in our facility is a provider who provides that psychiatric medication monitoring piece. When we're going to require an APRN to be that medical, clinical piece where they have to manage all of the referrals. So they're not going to be a provider. They're going to be providing oversight to the crisis intervention center. And they're going to ensure that all the statutes and regulations are adhered to by the CAC. So this is a loaded slide with a lot of positions. It's preliminary discussion regarding what the staffing demands would be in addition to what we're currently providing. I can see faces. It's a lot, isn't it? Yeah. So it's important to consider that the funding, we did get 1.5 million additional crisis funds with our KDADS grant for crisis stabilization and becoming a CIC. And then the CCBHC, we are going to be billing Medicaid for the services that we're providing in this CIC. So we'll get revenue generated in order to be able to support some of the funding. We're currently looking at the billing practices and opportunities outlined in the manual for billing. So we're seeing what services can be billed by the RNs, those positions that we're adding, seeing what they can be able to provide. So we're capturing the importance of each of those positions within the facility. And of course, when you add positions, there's supervisory demands to ensure that we're providing the care needed and obviously the performance monitoring piece.
I think that was kind of my question was, is this just CCBHC reimbursement dollars or are there extra dollars for being a CIC that come from the state? I think that was, I know there's a grant.
We're also looking at, so there's some there's possibility of crisis rates versus regular CCB. We're looking at all of those components. Again, early discussion on what those options are. But we did. So before we just got crisis funding for our department, and then we applied for the grant and we were awarded 1.5 million additional funds for crisis stabilization and our work towards becoming a CIC. So that's all supporting the operations.
Very helpful.
Any questions on this? I just talked about the grant dollars that we had. Really, the work is to divert, our project goal is to divert patients from admission to the state psychiatric facility and give them the ability to receive that short-term care quickly. It will decrease referrals to the state hospital, decrease referrals to the emergency department. So hopefully people with acute medical needs receive the care quickly because there's not an abundance amount of mental health patients awaiting inpatient psych beds. It aligns with our goals as a CCBHC, improving access, coordinating care with providers, increasing the quality of care, which in the end would improve our overall outcomes for a person's whole health. Does this have a laser pointer? How do I work? One? No, that's not. Is it? Okay, so this, I'm gonna try. I've never done this before, okay? Can you see it? Okay, so this is the first floor, okay? So if somebody comes in so this is for our typical crisis services that we provide now, okay? This down here is the Crisis Intervention Center entrance. Regulations require us to have a separate entrance. It's fun. I'm telling you, there's really, really fine details that you have to pay attention to. Security is, gosh, I don't know if I'm going to get there. If you look at the entrance, security, there's a vestibule and then the security will be right there. And then right here is the observation unit. That's the 10 beds. We currently, or 8. We currently have 6 beds. We're moving to 8. Below, that's the CIC. So the beds around are the 13 beds, and then we have office space along the side. Top, right?
Yeah.
Yeah, the top is north. And then the entire left side is SAC, social detox and sobering. The sobering is right there. It's a very busy building and we got in and we're like, how are we going to get everybody where they need to be? So this, I'm trying to think restrooms and stuff. I don't know how detailed you want to go, but this is really where the stabilization and detox services are. And then if you go to the second floor, this is where the north side, the top is where the waiting areas and the patient care rooms are for people walking in to receive services. So right there. And then towards the bottom right, that's our 988. These are all office spaces for therapists, managers, supervisors. This is staff break room, sink, restrooms, mother's room, lavender room, just like a debrief, and then conference area. These are all workstations. So some of the field-based work for those case managers that have specialized populations or are coming to work with patients that they're assigned to within the units, they can have workspaces there, plug in.
Repeat Commissioner Meitzer's question. On the right-hand side of this would be Topeka Street,
Yeah, that's Topeka.
would be the parking area. And then if we look up and left, that's going to be Biomed.
Yeah, so this is the parking lot and then Biomed is here. Yes. So there's gonna be, so the first floor, it's ligature resistant. So we can't have any risk for strangulation anywhere within the first floor because that's where care is provided. So there'll be ceilings, drop ceilings there. But the top where there's not patient care being provided, so minus the front, the north end and the 988, just because of sound, they're going to be on the phones. The rest, they'll maintain that ceiling, which is beautiful.
Jen, can you go back to the first floor? Okay, and where the CIC is at is, so that's,
Right here,
okay, so the entrance to that will be off of.
right
Topeka,
here,
or will be in
Topeka.
the alley.
Yeah, right here in Topeka. SAC entrance is up in the alley, right there.
And do we know, there is an alley behind there. Are we vacating that alley? Is the city gonna vacate? Does anybody know?
Do you know? I know that there was conversation about the alley.
Andrew Diltz, excuse me, Andrew Diltz, Director of Facilities. Yeah, the alley's being vacated, so a portion of it, it'll be shared between the city or the county and Wichita Biomed.
Connie?
I was just gonna say, Andrew, do you want to mention that that's also going to be law enforcement? That can be also the law enforcement.
Yes, so for SAC, their entrance is, I don't know what button that is. So the SAC entrance is right here, and so this alley, this existing alley today, we'll maintain it. We'll have an automatic gate here, and this will be kind of the back of house for Biomed. It'll also be the law enforcement drop off to SAC. It is.
If you want to go back through the next slides to get through the building piece of it, I think there'll be some questions. I have some questions on CIC in particular. So if we want to finish the building piece of it, that would be, there's 2 more slides on the building.
So coming into looking at the budget, our budget number hasn't changed since last month. One thing that, and I won't necessarily go through all of these line items, but one thing to point out, beginning of the year, we were estimating about almost $23 million for this facility. After putting it out to bid, we were able to reduce what we were estimating. And so our total is just shy of 20 million at this point. In our current progress, J.E. Dunn is working on the Biomed Center. We have a lease agreement with them so that they can use the building while it's set vacant. They are in the middle of vacating that building now and reducing their laydown area in the parking lot to phase 2 per our lease agreement. This will make way for Icon Construction to get started, who's going to start mobilizing at the end of this month. We do have Icon contracted to have completion by the end of 2026. So we're looking to start moving ComCare over at the beginning of 2027. Our FF&E has not gone out to bid yet. We are still evaluating options to try to reduce what we could possibly reuse for furniture and maybe look at reducing our estimated budget for that at this point. And then we are also evaluating options and continuing conversations on the parking, what the parking looks like and what the security looks like for this facility. But we are hopeful that we'll hopefully have an option here for parking in the near future that we'll be presenting to you.
Okay. We want to ask you about crisis intervention center stuff. So we're going to ask you about I want to ask about the parking. I know that sounds like a really benign topic in the whole grand scheme of this whole thing, but this is a challenge right now. Are we having any breakthrough with conversations with the city or with Biomed, or this is, we have to have places for people to park, staff to park, and how many staff are going to be on this site?
We're looking for approximately 75 parking stalls at this point. And the option that we have that we'll be presenting to you shortly will be a short-term solution. So we'll continue to have the conversations on what the long-term looks like.
Okay. Okay. We'll accept that for now. Other questions on the building piece? Take the chairs from the conference room. You can take them other places. Other questions on the building piece? All right, we got Andrew. Okay.
CIP was 22 million.
No, the CIP originally was 15.5 million and it was intended to be bond funded. And this is the one when we talked about at your retreat in February, we had that higher figure estimated. At the end of last year, you all authorized a pretty significant transfer of about $15 million from the general fund to the CIP fund. And we had two plans for that. One was to basically supplement the bond funding for the admin building. The other was to supplement the bond funding for this building. So we are still planning, and when the project is done and we have precise costs, we'll do a bond issuance to reimburse ourselves for up to 15.5 million. And then that gap we will fill with that cash transfer that you did last year.
Okay.
Fair, what the original year of this NCIP was?
21.
Yeah.
So we were talking about it in 2020, and I think the estimates actually came out of 2019. So yeah, there has been some significant movement with the construction market since then. So I actually think we lucked out.
Yeah. Well, let's talk finances piece of this. Obviously, we have a bond approved for 15.5. Is that?
So you all have authorized a project authorization amount. So
Okay.
Forget everything you know about the admin building. The way we typically do our bond funding around here is we spend the money first and then we reimburse ourselves with bond proceeds based on when we really know the final cost, so that we're not accidentally bond funding too much. So we will spend the money out of the CIP fund. Obviously, it will show a deficit for a while because we're essentially borrowing against the general fund. And then based on this timeline, if it's going to be completed at the end of 2026, we would plan to come to you in January or February of 27 and actually have a bond issuance at that time to reimburse ourselves for no more than 15.5 million. And then that debt service would be spread over 20 years from your bond and interest.
That makes sense. Okay. ComCare fund balance. You have any idea where we're at today?
Oh, your county manager just asked me that question. That's one of the reasons I stepped out earlier. So we are today at $28.15 million on a budgetary basis.
Okay, 28.1. I remember when I first got here, that number was not, there was challenges. I mean, it was almost insolvent. I mean, so this is the CCBHC influence and the capacity to scale. I guess my question is, and I don't expect an exact answer, but obviously this facility and these services are going to have to take on a significant burden for this community. How do we strategize? These dollars need to be deployed back to the community. How do we strategize what we need to reserve for the excess buildup and the scale up of these services versus, I guess I'm just trying to, how do we best utilize? These are dollars intended to get back, put back into the community.
Right. They're intended for service. And so you also need to remember that you do kind of a 3-year model of funding where you're, at least this last year, we were allowed to request based on estimated costs. Going forward, it'll probably be more likely to be based on actual costs. So there is some reason to spend the fund balance that you've got to invest in services. You do have, I also looked, their operating budget in this fund for this year is $58 million. So $28 million wouldn't even cover 6 months of service if there was a significant disruption at the
If we
federal.
just stop performing services all of a sudden.
Well, not if we quit providing services, but if we quit, let's say the Medicaid funding, because this is, as was discussed earlier, this is base Medicaid funding,
Sure.
right? So depending on what the federal government does, and we're hopeful that they won't touch this because it is such a national need. But that obviously is an area of concern. One thing we do know is if we do move that ComCare complex off of the watch list, that's a pretty significant cost too. It was right under $40 million. If you estimate that we would pay that from this fund, that debt service alone is at least $2 million per year just for principal over 20 years. And then you've got to throw in your interest costs, and who knows what our interest rate environment will be by that time. So there's a lot of competing needs in this fund. So I think that's part of the strategy conversation. I know these guys are all talking about that, but at a higher level from.
I'm just trying to figure out like do we have I know the conversations are happening, but how do is there a threshold that we need to maintain? Is that
Yes.
the approach?
Yes.
And what is that?
There is a threshold. There's some best practices from GFOA. I would tell you right now, based on the volatility at the federal level, the risk level is higher than it has historically been. So they would typically encourage us to hold back more than they typically would based on those best practices, because that's why in the general fund, property tax is stable. It's a stable revenue source. So we have less risk. So that's why this sounds asinine, but that's why we only keep 20% is because it's a stable revenue source. In a grant fund like this, a revenue fund, that's more dependent, as you said, it was practically insolvent during COVID when we had the fee for service model. We're probably looking, if it was just me, I would say 50% of the budget, but I'm not going to say that to you because I think that's crazy to say out loud. But I would encourage you to not let it get less than 30%. If we get to 30%, we need to start talking about what's happening.
I guess my question is, do we need to formulate some sort of policy around the approach here? I think there's going to be demand for these dollars to be put into the system. So I guess, should we formulate some sort of policy around what we're trying to aim at here?
And I think the biggest component of the system that we need to invest in is staff. I mean, Jen
see
talked
it.
about all of those staff that we need as we.
Kind of where I'm getting at, yeah.
And as we get to, as we continue to see more patients on the other side of the organization, the rest of the organization, there are staff needs there as well. So that I think is going to consume between facilities and then the staffing that we need to maintain. Community that continues to grow.
Yeah, I would just maybe encourage us to give thought to putting some sort of policy around what we want to do with this fund.
I think that makes sense. And I think one of the things that we could look at is plugging in this model into what is currently happening, give you some financial projections and get some buy-in from our ComCare team, their leadership team, our finance team that says this is where we're comfortable being. And then, yes, we can craft that. We can have a formal policy, but an informal policy might be best. So you can be.
Would be just as sufficient so we know what we're aiming at. I have some questions on the CIC if everybody's done on the finance and the building piece of it. How many crisis intervention centers are there in the state right now?
Right now, there's one, Burt Nash and Prairie View. I think there's one in Western Kansas. At Wyandotte, in process of getting their provisional licensure.
Are we going to be receiving courtesy placements? That's a corrections thing in my mind now, but out of county placements, things of that, are there going to be placements sent here for these purposes?
Generally, care and treatment is petitioned in the home county.
Okay.
But if someone comes to our doors and is needing assessment for service, we would serve the person, just like the CCBHC model and requires.
Okay. I'd also explore, as we're talking about policy and things of that sort, the CIC, if there's other revenue opportunities here. I think we need to dig in as deep as we can and figure out if outside of the CCBHC reimbursement rate to see if there's other opportunities here. And also just a point of reference that this is for adults, that there's a significant need for crisis intervention beds and centers for youth too.
And we do, and I didn't talk about that. We have a bed that we set aside for crisis stabilization for youth at the Wichita Children's Home. So we have contracted with them one bed continuously. It's not as we need it. So if someone is if a youth is requiring that service, we can make that referral. And if they have capacity to meet a demand for more, we can ask for that.
And when we don't have that bed is being filled and we have juveniles that need crisis intervention or stabilization, where do they go now?
So St. Joe serves
Okay.
12 and over, and then we have
Amber.
Camber.
Yeah.
We have Camber locally.
Okay. Boy, this ecosystem is changing by the day, and I'm grateful that we're trying to scale to meet the need. And just want to make sure we're utilizing these revenue sources appropriately.
Mhm.
Yeah, also $58 million in the ComCare fund. How much of that is property tax funded?
So that $58 million budget is just in their ComCare revenue fund. That does not include the property tax that would be included in the general fund. And
Less than
that's a
5
few
million?
million more, six-ish million, I think is what it was in the current year budget.
Okay. Other questions? Thank you, guys. Tim, thank you so much. Appreciate it.
You're welcome. Thank you.
Tim, thanks.
Well, while we're on human services, let's talk about WIC now. And I think Adrian is on Zoom, right, Kevin? Okay.
Is Adrian?
Okay.
So yesterday, KDHE had a webinar at noon to talk about WIC. And Lindsay mentioned the instability of the federal government right now and funding right there. And so that was the conversation that we had. The WIC funding year starts October 1st. And that is a reimbursement funding model for local health departments and states. We receive the funding through the state. So there's not much of a buildup of reserve to be able to spend through for WIC. So there are 3 different funding pools, buckets of money that fund the WIC program. One is the food funds. And so that's what gets loaded on a program participant's card and they take to the grocery store and purchase food with. That funding appears to be stable through the end of October. The administrative funds, nutritional service and administration funds, are what pay for the staff that do the work to approve people for, they assess them, determine what they're eligible for, and approve them and make those arrangements so that they can go purchase that food. That funding is probably going to expire within one payroll cycle of October. So we've got about 12 to 15 days of funding for those staff. And then there's a much smaller fund related to breastfeeding peer counselor funds. That's a much smaller amount. KDHE's recommendation is that we should anticipate that those funds will be last in coming back. I mean, there's still a belief that the federal government's going to adopt a budget. They will fund the WIC program and services will continue. But right now, KDHE is asking us to think about how much longer we can operate with the funds that are available and what kind of things can we do after that funding expires. And so, as I mentioned, we know that we've got funding for about one payroll cycle for those staff. And we also talked to you at the earlier this year about a policy related to lack of when federal grants go away, keeping those staff on board for a period of time so that we can continue to meet the needs in the community. The amount of food that's purchased through WIC funds in our community is over $700,000 a month. There are lots of folks that are fed, their nutritional needs are supplemented with that WIC program. And so it's a significant economic impact, and it's really important to those families as well. About 300,000 of that is formula for infants.
Wow. Okay. Some questions. How many people in Sedgwick County? Adrian, thanks for joining. How many people in Sedgwick County are on the WIC program? Do we have an idea?
We do. We actually have 9,000 participants on a monthly basis and there's approximately 5,400 what we call family units, because there can be more than one that's eligible for a food package because they're under the age of 5. or if the mom's breastfeeding, is pregnant, any child under the age of 5 that has some nutritional deficit are eligible. So there may be 3 in a family. So we say 5,400 family units, but over 9,000 participants because of those family units.
That's helpful. Okay, a couple thoughts here, and then good job with staff on the foresight of developing a program for staffing. I think that was very thoughtful. So thank you for, we have policy in place for these things now. The question though, on obviously the administrative piece, but on the food and the breastfeeding piece, quantify that. You said $700,000. My first question is, do we know how much funding is required monthly? Is it just the 700,000? The second thing is this reimbursable? So if we meet the gap until the federal government does it, do we get reimbursed if we were to meet the gap to keep a program going?
We would not expect to be reimbursed. And I do want to clarify, the administrative piece is paid by the county. That staffing, the food costs are paid at the state level.
Yeah.
We don't actually buy that food ourselves, but the kicker is, if we think that funding will run out by the end of the month, and if we don't have a federal government budget, and if the state doesn't step in, at that point, we may need to talk about taking on new additional costs that has historically not been passed through us to purchase that food in some way. We have some time on that because, as Tim mentioned, right now the state says that should most likely last through the end of the month.
So
Right?
the state is indicating to us that they will cover this cost?
No, they have not indicated that yet.
Okay.
And
They have money to do it now through the end of the month.
Okay, I guess my next question is, if we get into a point, which I cannot imagine, but if we get into a point to where the funding is run dry and we have 9,000 people here in the county, keeping in mind we won't be reimbursed, is this a significant enough crisis that we need to dip into some funding to sustain a program?
I believe so. Yeah.
I would argue, at least for that formula piece,
Yes.
that's pretty critical.
that's
It's
kinda
that
where my head's at. I just wanna-
$300,000 a month. I would say that in terms of core functions, this is a pretty core function. That's 300,000 per month. And then again, this is food that's purchased for folks on a food card. If the state system shuts down, we won't have access to that
So how-
system. So we will have to spin up our own program. And I know Tim and Adrian and their teams have been talking about it. So I'll let them speak to that.
We've talked through a lot of different options, and our best option is that the federal government passes a budget and this program gets funded. If not, we've talked through a number of different options. None of them are going to be as elegant as the current system, but we have figured out a couple of different ways. If we get commission support, spend money that way, we have figured out ways that we could, at the very least, get that formula and a limited food package to families so that they could continue meet their nutritional needs.
Just a point of clarification, is the 700,000 over $700,000, is that including what the formula is, the baby formula? Okay, and so did we say 300,000 of that is formula? So we're ranging from anywhere from $77 per month to $129 per month on just those numbers, 9,000 participants or 5,400 family units. What is, if government doesn't budget for this and there is a gap, is this something that the community can help support? What are some of the regulations or red tapes that we need to know about?
If there's no federal funds, there's no red tape, and we can design a program, and we just have to stay within the limits that you recommend for us. There are also community resources. And so we work with families right now to say, here are food banks that are available in the community. It's just that food banks are stretched pretty thin as it is. This would be an additional burden on them as well. And so there's going to be a nutritional gap if this program doesn't get funded at the federal level. We just know that's true. We just have to figure out how can we mitigate that gap and decrease the damage that does for folks.
So it sounds like the options in that nuclear case is we meet the gap, or the community alone meets the gap, or we do it in combination. So we're developing some strategies, the what if strategies. Okay.
And one other option Lindsay mentioned, the state also has a fund balance, and there may be an opportunity to advocate for the state to utilize some of that fund balance to help address this shortfall as well.
I do think that's really interesting. So Tim and I were talking yesterday, and Sheena as well, and Nicole. But one of the things that Tim mentioned is these are programs that are run at individual county levels for the most part, 103, 104 different counties. So right now the state is asking each health department for its contingency plan for this. It's due today. That's why we're asking to have the conversation today. But there's the potential that there's going to be different WIC programs for these individuals across the state. If the state isn't stepping in, it's going to be relying on individual county commissions to step in and fill the gap or not. So I agree. I think some advocacy to our state partners, if the feds can't get this resolved in a timely fashion, would be helpful. Because that could be really impactful.
Yeah. Okay, Commissioner Howe.
I was just thinking the same thing. It sounds like just logistically, the state should be the one that provides the benefit. Because if we try to do it, the pay mechanism doesn't even work for us. If you want to hand out formula, that doesn't work either, because there's literally, different brands and different kinds that the babies are used to. And that logistically, we can't just provide formula. That is, physically it doesn't work. I think the state needs to provide, the benefit, simply because I just think that logistically, there's no other way for the county to do this ourselves. If we have to do it ourselves, I agree. We're going to meet the hunger demand, but I don't think it's not the right way to do this. We need to get the state to step up and provide the food benefit directly.
Thank you. So either Tim or Lindsay, you sent us an email yesterday that could we, based on this discussion, could we have it in a more condensed, what the bullets, because that one that you would be okay with us sharing to our other, in the community. Obviously, I don't know if the media wants to know about this as much, but if we have to circle the wagons with other nonprofits or whatever, I'm not sure that I can make a request, but I think that they all should be aware of this. And I said, when you said we have time, and then you said the end of October, I'm like, well, that's not time in my book.
Well, and let's be clear, for that administrative side, we don't have time. We are expecting that funding to run out by the end of this week. And so we will be stepping into that gap with that 60-day policy that you all authorized. And then if we need to come back at the end of those 60 days and talk about strategy, we will. Obviously not the full 60 days. Hopefully we have a federal budget within 60 days. But it's that food part is the second part. And yes, you're right. That's the one that ends at the end of the month. So, I mean, in terms of administering the program, we are there to have to make some decisions. That's why we were going to wait till Friday to have this conversation. But then seeing Adrian's email this morning that the state needs a contingency plan today, we thought we needed to escalate this sooner.
Okay, well, if we, or at least I could get a summary that you're okay, that gets shared publicly. Thank you.
Okay. That's a helpful update. So regretful update, but helpful. Yeah. Yeah. Okay. Thank you. Thanks, Adrian. Appreciate it.
We'll shift gears now, and Tanya's going to talk about on-call commercial real estate broker services.
Hey, Tanya.
Hey, good morning, Commissioners. Tanya Cole, Assistant County Manager. So I think it was last Friday, we had a discussion that it was on-call real estate broker services was on bid board, and there was a request to have this brought before staff meeting. So that's what I'm here to talk about this morning. Okay, so to give you a little bit of background, purpose of services for on-call real estate brokers. I just pulled this out of the RFP, and I'm just going to summarize this for you. So what we look to for the on-call real estate broker services is just to assist the county with purchase or lease of real property, to help us research market information and help us prepare. They help us prepare price opinions on land or leases, consulting services, which include site inspection, and then of course just customary services associated with real estate transactions, as well as negotiate with sellers and property owners on behalf of the county. They then inventory properties that the county has considered, and then they provide cost analysis for easement considerations and CIP budgets. The current process that occurred on this recent RFP and what was brought to you on the bid board for on-call, there was a current bidder list of 91. And how that works is if any bidder wants to do business with the county, they register through purchasing, and they are then added as a provider on that bid list. And then also purchasing will use the Wichita Business Journal provider list, and they are then added onto that list. And then purchasing also uses the annual list of lists for top providers for various business services. As far as the history of how this has come up, back in February of 2014 is when we started this. NAI Martins was our first one. They had a one-year contract with 4 one-year options to renew. And then in February 2019, NAI Martins was again chosen, and that was a 1 year with 4-year options to renew. And then in June of 2021, we had 3 on-call real estate brokers. That's CBRE, Reese Nichols, South Central Kansas, and Lang Real Estate LLC. And that was 2 years with 2 one-year options to renew. So currently what we do with our on-calls, basically the process of what we do with them is we identify our needs. We then release the realtor to identify all properties meeting that needs, or to ask them to find properties that meet the needs. The realtor then compiles and presents that to the county. The county then identifies properties to tour. The county then selects property or properties, and then the realtor will negotiate lowest and best pricing, and then we present those to the commission. So I just want to give you a little bit of background on buildings or leases that we did without an on-call. Back in 2002, we had the ComCare Center City lease on Topeka. In 2007, we had the aging lease at the Riverside Hospital. We had various leases at Harry Street that included the appraiser. In 2008 and 2009, we had corrections. Now, those were a couple leases out there. And then in 2017, we had ComCare. 2009, we had ComCare children's lease on Broadway. 2010, ComCare lease on Amadon. 2010, ComCare lease at Twin Lakes. And then in 2015, we had 2 buildings that were purchased, the Douglas Tag Office and then the Law Enforcement Training Center. Those were done through an RFP process for turnkey facilities. And then buildings or leases that we've done with an on-call. In 2014, we had the Ronald Reagan Building done with NAI Martins. 2019, the Fire Station 31 Andale Land with NAI Martins. 2021, ComCare Crisis Center search. We never did follow through with anything on that. That was done with CBRE. 2022, the Ruffin lease with Lang. 2022, Health Department Clinic with Reese Nichols. 2023, Envision 911 parking lot with CBRE. 2023, we had the Emergency Preparedness Center land with Reese Nichols. 2024, ComCare Children's lease with Reese Nichols. 2024, Mental Health Hospital land, Reese Nichols. 2024, ComCare Crisis with Lang. 2025, EMS Post 1 with Lang. And then in 2016 through 2025, the elections building that was done with NAI Martins and Lang. 2018 through 2025, the admin building with NAI Martins and Lang. So this is my take. We had on the benefits of an on-call real estate broker. As you can see, as I kind of reeled off all of these, greatly reduces amount of staff time involved in vetting properties for county needs. I feel that it insulates staff, leadership, and commission from any insinuation of special relationships or backroom deals if done through a representative working on behalf of the county. And then we have subject matter experts with innovative methods to negotiate and fulfill county needs through purchase agreements and leases. So I just kind of put together what I believe are the three options to move forward, and there may be another options that commission you may have. But first option would be to continue with the bid board recommendation. Second option would be to utilize facility staff and purchasing process for ongoing building acquisition, disposition, and leases. So that would be to not use an on-call real estate broker service. And then third would be to put the RFP back out to see if there's any more interest. And so I'm happy to answer any questions you might have.
Thank you for putting this
bet.
together and make reference to the commission. Joe's back here too as well. So if
You
you have
bet.
any specific questions about bid board. Okay, questions, Commissioner Bluebonnet.
Thank you, Chairman. Do we have any idea how much commission was paid out during that?
We do. We can
just looking at all those transactions, I would assume that'd be, do
Yeah, we absolutely would have that. We can get that for you.
you have any ballpark idea?
Well, typically, if I go back here on when properties are being sold, it's the buyer, it's the, let me just get this right. If we are buying, the buyer is the one that's selling it, paying the commission to the real estate broker. Now, it's going to depend on deals because we've had deals where in some cases we're having to pay the commission. So it depends on how that deal gets negotiated. But we can certainly look on all of those purchase agreements, how that commission gets.
Like the
done.
Envision building, man, we're picking up both sides of the.
That is
commission on
correct.
that, right? And that's a very large transaction. And I guess I just get back to, my real estate experience and procuring cause and what leads you to earn a commission and what doesn't. We have a checklist that we have to go through.
Yeah.
Coming from the city side, I'd like us to look into that practice a little bit about how the city does it. They have one person inside there that kind of runs the real estate department and they issue the RFPs. It seems like the amount of dollars in commission we're paying out. I'd like to at least maybe even look at what it would be like if we had an inside person. I mean, I think there's plenty of work to be doing. They can be doing BPOs. I mean, with the amount of real estate transactions we do, I just like to look at the advantages and disadvantages of having somebody on.
And let me back up because I said that incorrectly because I have to think about this sometimes. When we are buying, the seller pays the commission. So, and when I say it depends on the deal, it truly does depend on the deal and how we go in and negotiate. But typically in a purchase acquisition, the seller is the one that should be paying the commission to both the buyer's agent and the seller's agent. And when you look on the fees that we have for currently what's in the RFP, that's how it's split between the buyer's agent and the seller's agent. So typically that's how that works. But again, it all depends on, and you brought up the correct one to bring up. It all depends on how we're negotiating something we want to buy.
And one of the statements on here too, where it insulates staff leadership from in situation of special relationships or backroom deals. Some of the transactions we've had were with the agency that we hired to represent us. So I don't know that it's insulating us the way you stated it here.
Are you, for example, bringing up, help me understand which one you're talking about?
I guess specifically when we get into it, all the Lang properties, from the lots, from the purchasing the property for the mental health hospital, from purchasing the property across the street, from, several different transactions. It appears as though we're doing business a lot of times with the folks that are supposed to be representing us. And it would make one question, where's the fiduciary responsibility?
And I understand what you're saying on that one in particular, Commissioner, but we had a different agent on those Lang properties represent us.
The mental health hospital went through a completely different process. It wouldn't have been one of these because it was a state-led deal with different players. Yeah, and it was donated. So I do want to clarify that one. I understand what you're saying, but for the public, I want to be clear that was not our typical process because it wasn't our typical project. So the fiduciary responsibility, I think, was adhered to on that one.
I guess I would at least like us to look at maybe a cleaner process.
One thing I will add, Andrew Deltz, Director of Facilities, a lot of these transactions that you're seeing here are very recent. The construction, the expansion, our CIP, it really kind of exploded the last few years, and future transactions that we have currently planned on our schedule are fairly limited. We do have the ComCare complex that's lingering out there. There may be one or two other transactions that we will have in upcoming years. And so I don't know that bringing on additional staff for those limited transactions would justify the cost of that staff with what we're forecasting for the future.
I mean, right now we're looking at, the Envision building alone, aren't we looking at $900,000 for the commission?
I think it was close to maybe, I think it was a little over 500,000.
For both sides.
Yeah, it was about 358 for our side, and I think it was a little 150 for their side, I think, but I'll double check it.
Are you ready? Okay, I didn't want to interrupt you. I'm sorry. I'm going to take a little bit of a different angle. As everyone knows, I'm a commercial broker. So I really appreciate the time that commercial brokers put into, especially government deals, because sometimes they're years long. I'm curious, NAA Martins and Reese Nichols, neither of them responded to the RFP. Is that correct?
That's correct.
Do we know why?
I don't know why, Commissioner.
Okay. Thing I will feel more strongly about are the contracts that we sign. I don't know that I feel that it's necessary to even have a contract. I think if we know that we're in the market to be a buyer or a seller, we can engage those that are on maybe a short list and I guess more of a bid type of approach where we put it out to them and they can tell us whether they want to work on it or not. But what I've been maybe disappointed in is our agreements with these brokers are not real advantageous to government side, to the county side. I'd like to see it tighten up to where I've talked to you about this a little bit. Commissions usually scale. When you're talking about a $13 million building, you're not getting a 3% commission. I'd love to receive that myself too, right? But that's not typical in our industry. Usually it's scaled down. So I would be interested. I can support if we want to have these people on call. I know it's hard. I would never try to do business with Sedgwick County because my time would be so limited as a commercial broker, right? So I understand that it's a gift to have them on call and that they do a lot of work. I just would really want to see that if we do that, I want those contracts to be a little tighter, knowing that, when there is a payday, it's going to be worth their time. There's just going to be time before that probably.
Commissioner Wise, Justin Widener, County Councilor, I did want to add in, if that's an interest that you would have, I think something that might need to be done would be modifications to the RFP, because usually these contracts reflect the terms and conditions in the RFP. That's certainly something that the county could look into. But I wanted to mention that because once we've gone out to RFP, accepted the bids and entered into the contracts, it's not going to vary from what's in the RFP usually.
Do we have real estate that's hot on the, that we need to address quickly right now?
We've got a couple items that we're working on right now, but I mean, they can be done with staff.
Okay. Well, I'm just not sure. I don't think that we're left exposed if we don't have someone on hand. I think we have good connections and relationships with previous people we've worked with. I'd like to look at that, maybe just what that RFP language looks like, tailor that a little bit. And then just as I think Commissioner Blubaugh would be okay with as well, as if it is more of an RFP by the project, maybe instead of having an overarching agreement with someone, again, it's to protect them. It's not necessarily to protect you when you have someone, when you're in a listing or an exclusive client agreement with a broker. So just my thoughts.
So the alternative to not having an on-call broker would be if we have a project we're seeking real estate for, it would be to send out an RFI that we would ask for responses to, and then we would, how does that work?
Or RFP. What she just suggested is on the individual buy, we would put an RFP out for a realtor to handle that
Oh,
individual.
Yeah,
I
you
fully understand that sometimes the response on those aren't great. And so I see the strategy of having someone that works just for you. I get that. But yeah, I think.
hi, Joe.
Hey, good morning. Joe Thomas, Purchasing Director. To address the RFP, generally that takes 8 to 10 weeks. So if we did each individual property, we would have that period of time to do. What I'd also like to suggest is I could look into best practices of other municipalities or counties, similar sizes. How many of them do have on-call services as opposed to ad hoc services that they do on their own, and provide you with that information.
I guess I try to think of a situation where procuring cause, you're bringing a property or you're helping selling. Well, what about, and I know we want a clean process, but what if someone brings a property to the commission? Then all of a sudden, does it really need to go to that third party, or do we have staff that can evaluate that property? Does that somehow taint the process? Or
Can you speak to the charter, Joe?
Yes, what we can do, and we have the on-call, we also have the ability to say, we're in a particular case, we will not be using the on-call vendors. We've done that in the past. And we say this particular project, we're not going to use the on-call vendors. We could pick and choose, I guess, is what I want to say. So you have a situation like you're mentioning, special property. We either can have them offer, or we can particularly go back and do an RFP just for that property in itself and kind of segregate it out. Does that help?
What's the last time that we updated our policy for purchasing or disposing county real estate?
Ooh. Or, yeah.
So there's the Charter 68, which is the procurement part of that. And we really need to crack that thing open because it still has reference to Legistar, which is a system that we moved away from multiple years ago. The challenge with Charter 68 is it takes a super majority of you to approve those, and there's a 60-day delay. And when we've talked about those things in the past, that's been a challenge. So that last time that was updated was early 2017. We'd love to update it, but it's been a challenge when we tried it before. In terms of the surplus disposition policy, it's been longer than that. We are looking at that now just because of some of the conversations that we've heard from locals, and maybe potentially breaking out the real estate component of that from the personal property component because it is so different. So I think the time is right to look at that one. And we can have a separate conversation on that. Since that's not a charter, that's much simpler.
Yeah, I mean, being 8 years old, the world's changed a lot, post COVID and stuff. I wouldn't mind taking a look at that.
Chairman, I did want to make a quick comment. And Charter Resolution number 68 would apply to what we're talking about here, the on-call services and any contracts for that. But actually, Charter Resolution 68 is not required to be followed for the acquisition of property. So that's just, we just have to follow state requirements, but it doesn't actually specify or limit how we acquire property. And so I don't think we have a technical policy in terms of how we acquire property, other than the county commissioners are the only ones, unless they delegate that authority, who can actually make a purchase of real property. But
just one other thing I want to throw out there is the importance of the broker price opinions and having someone from the market take a snapshot or do an appraisal, because if you look at some of the purchases that we do, they're not congruent with what the tax value is. We can't really depend on our tax appraiser when we're doing real business, because I just don't see those values as close as what I've looked at anyway.
I may be the oddball here. I'm sure I am already. I don't think the system's broken. I'll just say this, that, I think every system's going to have potentially some improvement opportunities or some flaws. I don't think that we have a perfect system, but I don't think it's broken either. And I say that because some of these things we've done, I think we got extremely good representation and a very good market deal. I look at the LETC, for example. That's a crown jewel, in my opinion. We really did great on that process. And I'm very proud of everybody involved in that one. I wasn't really happy about the Reagan building when I first got here. That was the deal was made right before I showed up. I didn't think that we got a good deal. And I have to say, it's just an opinion. It doesn't mean I'm right. But I looked at that, and what I foresaw was it seemed like we were picking the building before we negotiated the price, and the price did not change in our favor because I think we were kind of committed to the location and the idea too early in the process. And the public, I think, was very aware of that. So I'm not saying that's exactly what happened, but I was suspicious that we didn't get a good negotiated deal. There was a lot of people in the community that said we paid way too much for that building. And I'm not saying that they're right, but I'm saying that I'm suspicious that if the public feels like we are committed to an idea, we may not have a lot of negotiation power at that point. So it's almost like saying, I'm going to buy that house. I'm going to buy that property no matter what happens. Now tell me what the price is. You don't have a lot of negotiation opportunities. When you have an in-house real estate person that makes that initial contact about a building, I don't know how much negotiation power we will have in that situation. By using the on-call, I think it insulates us from the public knowing exactly who the customer is. There's a lot of value in that, because they might come out and say, I'd like to know more about this building, but they don't know necessarily who the buyer is. I think that's a value to us to have that not known on the front end. And I think if we used our in-house, I think that would be almost nearly impossible for that to happen. I do agree that on a large scale purchase, we probably should negotiate the amount that's part of the points that we're paying for the commission costs or whatever that would be. I think there's value in that discussion, but I also think that they're not going to make a small amount of money on a, $10 or $20 million purchase. So we need to be we need to be reasonable as well. I can say also that the building we purchased, the tag office at 2525 West Douglas, that was one of those things where we looked at that building, I think 2, 3, 4 times before we actually made the purchase. And every time we looked at the building, the price went up because we were not able to actually commit to the deal. In fact, I think we looked at the Envision building years ago before we actually chose it this time. That we looked at that building a long time ago, and it's a very unique location and a very unique size. And it's obvious why we might be interested in that building. I think there's a lot of campus idea there. I think that at the end of the day, it's hard to negotiate these types of buildings because we're such a unique customer and these are such unique buildings. So I don't think there's going to be a perfect system. I'd also say there have been some times in the past where the BOCC has got overly involved in putting together some kind of an idea or deal. And I think that we need to be very careful if someone does approach one of us is to turn the idea over to staff immediately and get our on-call involved. If we're going to go forward with some idea that might seem like a really great idea, we need to remove ourselves as commissioners from that process entirely as early as possible. And I just think that we've had some challenges in the past where we've gotten maybe involved in kind of brokering a deal, even talking about perhaps costs and stuff. It's not appropriate that we would do that. So I like the idea that we have right now on call that does a lot of this for us. I think it does insulate us. It's really a good system. Is it perfect? Probably not. I think there have been times we paid maybe a little bit more than we should have paid for something or paid a little bit more commission than we should have paid. But the system overall has worked very well for us for a number of years. And so I don't think it's broken. I just think that maybe some slight criticisms around the edges that we could probably say we can improve it here and there. But I don't think the system needs to be completely replaced with a different system. And again, I think maybe other municipalities maybe should look at what we're doing here, because I think we do things pretty well sometimes. And I don't think we're the worst player out there. I think we do a pretty good job overall. So thank you.
Okay. I see Tanya feverishly taking notes. Do you think you have what you need to move us forward? And
I do. I kind of summarized. I'm happy to repeat that, but I think I took good notes. You tell me what you'd like me to do.
well, we have a couple different plans, a couple different strategies here that we'd like to go. I do think I'd like to see Joe's analysis, if that's okay, just on what could be as we build these things out. Is there an urgency to get this back on? This was a bid board item. When is it scheduled to come back on anytime?
We had this discussion during the BOCC meeting. I think it was good for 60 days. And I think we should do it the right way. I do want to bring up what Commissioner Howell said. The reason we went to on-call, as in my recollection, and I wasn't the manager then, was to make sure that the county could be anonymous in some of these deals, because you could negotiate better. That was the ultimate reason why we did this. I will tell you, just as a student of government, acquisition of real estate is going to get you into trouble faster than anything else, and a manager and a staff. So whatever we do has to be transparent. It has to be fair. Even if we do have to pay more, it's more important to be transparent. And this commission, the people, always make the final decisions. So whatever option we choose to do, as long as those stay in effect, that it's transparent and the people make the final decision, I'm good with that. And we're willing to explore other opportunities and peer analysis. But no system, I agree with Commissioner Howell again, no system is perfect. But we will always err on the side, and we will even cost ourselves money if it comes at the cost of transparency. I just want to make that clear, that we were going to be above board with real estate transactions.
And I'd like to just make one more comment. If you look at the admin building and the election office, both of those have taken literally a decade to get to a decision. So we have been extremely thoughtful and careful not to make a quick decision, and not to, I didn't necessarily agree with the election office personally, but again, I don't blame the county for moving forward finally. I think the commission felt comfortable because they just spent so much time trying to figure out the right answer. So at the end of the day, it's hard for me to criticize our process. I think we've just been incredibly judicious and careful in our decisions we've been making here.
I would just suggest, why don't we table the on-call realtor portion of the bid board, we give it some analysis, we look at other options. We have Joe and Justin, or a team, we'll do some peer analysis of what's going on around the country. We'll bring something back to you.
Bring it back, do it in staff, do it in 221s first, maybe, so we can kind of vet some of this stuff out and really talk through it. And then
Just one other thing I wanted to add is, I had a couple very qualified commercial realtors reach out to me and didn't know anything about this process, didn't know anything about the opportunity to apply. And I know you said you'd sent out to 95 people, the Wichita Business Journal. I think we could have broadcasted a lot more than just 95 realtors. There's a lot more going on here, and the Wichita Business Journal, I would almost say that that's skewed by their subscribers and people that, if you're just going off their list, a lot of times that's people that advertise with them and participate in their activities. So I think there's a lot broader audience we could be going out there if we're going to go the on-call.
We also post this on the website. The list is to make sure those who've actually applied definitely get a copy of it. But then we also have that on the website for a number of weeks. In regards to the timeline, the bid was open, the proposal was open August 12th. We're given 120 days. So the pricing will remain in effect till early December. Once that expires, they could retract their pricing.
One last thing on the list of 91 that got that. I looked through it. There's several that are not, they shouldn't be working on any of this, but there's several that aren't on there at all. So I don't know how that list is just continued and built.
Yeah.
If it could be scrubbed out maybe a little bit. I don't know what's appropriate for me to help guide or give some influence on how you should maybe do that. But I did see a lot on there that I don't think are even qualified to do the job. We have a lot of really great people in town that can, and it'd be interesting to see who'd be willing to step up if they did, get the notification. And some of them are just individuals that have, they don't have a shingle anywhere. And so you wouldn't necessarily know about them. And so how we can expose them to you, or if they're even interested, maybe make that introduction. I don't want to be involved, but I could certainly help maybe dwindle that down.
Yeah, please direct them to me personally. Be happy to give them the information, bit of registration to get them on. Another problem we have sometimes is you'll get an email from someone who's interested. That person leaves, then the company doesn't tell you about the update. Generally, what we try to do, if we send the email out and it bounces back to us, I instruct the purchasing techs to contact the company and say, give us a new email. give us new contact.
Helpful.
And we can give you that link too, to the bidder registration form. I don't know that we necessarily can purge it because we do allow them to select what they want to receive notification for. But certainly we can get that pushed out so you can get it to the right people so they can register, and then they will get that direct email communication that says this is open and available at any point in time.
To further on Commissioner Wise's comments, these real estate brokers, they're, you think you're hiring a brokerage firm, but it's an individual contractor. You're hiring that person. And there's been so much shifting of commercial realtors between brokerages. I'm afraid that maybe we did miss some folks that could really serve the county well.
To be clear, if they're not registered, they're not going to receive a solicitation for a response.
If
that
they're
correct?
not registered, if Joe's team will find them in the list, they can and push it out. But then, yes, it's also the bidder list. Otherwise, they have to know to come to the website.
I guess what I'm saying is we do want our potential vendors to register
Yes.
so that there's a
Yes.
fairness, if you will.
Yes.
If we simply cold call people, we might miss some. Again, it's almost not fair. to
And
say,
right, it's.
we reached
it's
out to 4 or
fairness
5 we
if
knew
you-
about, but we didn't
Right.
reach out to the other 4 or
Right.
5 we didn't know about. That's almost not fair. So it's really upon them to be registered as a vendor to potentially receive some business from us. And then we would reach out to them in a fair manner. So the fact that someone didn't get a solicitation for a response could be that they just did not know they needed to register.
Most likely.
And we participate with USD 259, City of Wichita, WSU, different expos and many procurements. Like last week, we went to the Wichita Chamber of Commerce Expo. We have a booth and we have instructions as to how you can sign up as a bidder, or we'll do it right there. We'll sign them up if they have any concerns about how to do it. We do try to reach out, but if you know of anyone, please encourage them to contact me. We'll immediately get them on.
We revise this and we put it back out. Is it something that maybe we could work with communications on where we can put it on social?
Sure. Yes, ma'am.
Because that's what I'm thinking. Most commercial realtors, and this doesn't come up very often of a bid to be the on-call realtor for the county, they're not going to know, they're not going to think about it. So if there's some kind of broader communication plan that we could come out with to maybe attract some folks that we normally wouldn't set eyes on.
Good discussion. Joe, thank you. Tanya, thank you. Appreciate it. Andy, thank you. Okay, do we want to tackle legislative platform?
A couple of choices here. We could, we have agenda review on Friday. We could tack a half hour onto the back of that new legislative platform at that time, or we can tackle it now.
Do you guys mind if we do that on Friday? Let's do that on Friday. Give everybody, we've gone a couple hours here and had a really good, robust discussion. And I think there's some things developing with some legislative partners that we might need till Friday to be able to update appropriately. So, okay, that's staff meeting for today. No, we have local consult, KDOT's local consult tomorrow. Lynn Packer, the star of the show, will be there. And then see you in agenda review on Friday. Okay. Have a good one.